Hello everyone, welcome back. Today I'll be covering OSCE question and answer. Happy practice. A 13-year-old national athlete complained of pain during sprinting in a tournament. He heard a pop sound in his right hip joint. The X-ray taken as illustrated. What is the diagnosis and clinical presentation of this patient? Answer is, it is an avulsion fracture of ischial tuberosity, AFIT. Clinical presentation in young active athlete, complaint of pain and swelling of the affected hip, inability of the patient to sit or walk, no ecchymosis. There is obvious tenderness at the sciatic tubercle, presence of palpitation of bony prominence and feeling of bone rubbing, absence of flexion or extension of the affected hip joint, and has no abnormal nerve symptoms. What is the mechanism of injury? It is a relatively rare injury. The ischial tuberosity is the origin of the hamstring muscle. In a young patient, the epiphysis was not yet closed, and the bond between the epiphysis and the ischial tuberosity was weak. When the hip was strongly stretched and bent, whereby the knee extends and the hip flexes during contraction of the hamstring muscle, the strength generated by the contraction of the hamstring lead to the ischial tuberosity epiphyseal avulsion fracture. This is associated with strenuous exercises, example, running, soccer, and other competitive sports. Rossi and Dragoni reported that the average age of pelvic avulsion fracture is 13.8 years, mainly due to the characteristics of bone development at this time. However, although the bones of the elderly are matured, there are reports of avulsion injuries in the elderly, in which case a pathologic fracture needs to be considered. What are the treatment options? There is no consensus regarding the treatment of avulsion fracture of the ischial tuberosity. The general rule is to choose the treatment method based on the degree of fracture displacement. Conservative treatment is suggested in a small degree of fracture displacement, but this is questioned by Sika et al. They reported in patients who had only 5 mm displacement. You can see it via CT scan that developed significant reduction in muscle strength. Hence, they suggest based on functional recovery and tolerance to injury. Avulsion fracture of ischial tuberosity with degree of fracture displacement more than 20 mm should be treated surgically. This is based by Bedded et al., while Ferlich et al. Argued that surgery is needed when the fracture displacement is more than 15 mm. Other operative indications include acute injuries, patient with neurologic symptoms, and after failure of conservative management. What are the complications if treat the fracture conservatively? There is risk of A. Non-union, B. Hamstring shortening and fibrosis, C. Pseudoarthrosis of the ischium, which lead to chronic pain during walking, D. Leg muscle weakness and unable to sustain sitting position for a long time, E. Sciatic nerve compression. What is the difference if this injury occur in active athlete person compared to a normal activity person? In active and high-demanding individuals, surgery is preferred in order to achieve successful anatomic reduction, elevate symptoms, and help athletes to return to full activity as soon as possible. Additional notes. What are the attachments at the ischial tuberosity? The hamstring group of muscle arise from the ischial tuberosity. These include semimembranous, semitendinous or semitendinosus, bicep femoris, but remember only long head. In addition, adductor magnus has fibers which arise from the ischial tuberosity, the hamstring portion. All are supplied by the tibial branch of the sciatic nerve. This picture shows the muscle attachment at the ischial tuberosity. You can see the semimembranosus attachment, semitendinosus attachment, long head of biceps at the posterior part, adductor magnus, only hamstring portion arising from the ischial tuberosity. Yay! We have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.